Imagine a child who cries endlessly at night, not because of hunger, not because of fear, but because their very own blood is attacking them. A disease that turns life into a battlefield, where each red blood cell becomes a soldier gone rogue. This is not just any illness, it is sickle cell anemia, a genetic time bomb that has been shaping human history for centuries. Today, we unravel its mystery. Stay with me till the end, because what you'll learn today is not only life-saving knowledge, but also the blueprint every nurse, doctor, and medical student must carry in their mind. Sickle cell anemia is a hereditary, chronic hemolytic anemia, caused by a single genetic mutation in the hemoglobin gene. This mutation transforms the normally round, flexible red blood cells into rigid, crescent or sickle-shaped cells. These abnormal cells cannot flow smoothly through blood vessels, leading to blockages, pain, and organ damage. History and evolution. The story of sickle cell anemia begins thousands of years ago in malaria-endemic regions of Africa. Scientists believe this genetic mutation survived because carrying one defective gene, what we call sickle cell trait, gave protection against malaria. But when a child inherits two defective genes, one from each parent, the price is devastating: full-blown sickle cell disease. Did you know? Sickle cell disease was the first ever genetic disorder to be identified at the molecular level in 1910 by Dr. James Retic. This discovery laid the foundation of modern molecular medicine. How dangerous is it? Make no mistake, sickle cell anemia is not just anemia. It is a multi-system killer. It causes stroke in young children, kidney failure in teenagers, chronic pain crises in adults, and shortened life expectancy if untreated. Globally, over 300,000 babies are born with it every year. The danger lies not just in the anemia, but in the silent blockages that strangle vital organs without warning. Causes. Let's simplify it. Normal hemoglobin equals hemoglobin A. Defective hemoglobin equals hemoglobin S. Sickle cell anemia occurs when a person inherits two hemoglobin S genes, one from each parent. One normal plus one sickle gene equals sickle cell trait, usually no symptoms, but carrier. Two sickle genes equals sickle cell disease, symptomatic and life-threatening. This tiny genetic swap, a single change in the DNA coding for hemoglobin, leads to catastrophic consequences. Pathophysiology. Here's what actually happens inside the body. 1. Mutation in hemoglobin beta chain hemoglobin S forms. 2. Under low oxygen, dehydration, or stress hemoglobin S polymerizes, sticks together. 3. RBC changes shape from round disc sickle-shaped rigid cell. 4. Sickled cells fragile, short lifespan, only 10 to 20 days versus normal 120 days. 5. Hemolysis occurs leading to anemia, jaundice, gallstones. 6. Sickled cells clog capillaries, vaso-occlusion. 7. Vaso-occlusion ischemia, severe pain crises, organ damage, spleen, kidneys, brain. So, the body enters a vicious cycle. Oxygen shortage creates more sickling creates more blockages, and more blockages create even more oxygen shortage. A deadly spiral within the bloodstream itself. We've seen how the blood itself turns into a weapon in sickle cell anemia. But how does this silent killer show itself in real life? What clues does the body give us? Clues that every sharp-eyed nurse or doctor must pick up before it's too late. Let's unravel the symptoms and their hidden rationales. Clinical manifestations. 1. Anemia symptoms: fatigue, weakness, pallor. Why? Sickled cells die early, 10 to 20 days, leading to chronic hemolytic anemia. 2. Pain crises, vaso-occlusive crises, sudden, severe bone, chest, or abdominal pain. Why? Rigid sickle cells block small blood vessels, ischemia. 3. Swelling of hands and feet, dactylitis, often the first sign in infants. Why? Blocked capillaries cut off blood flow to tiny bones. 4. Jaundice and gallstones. Why? Excess breakdown of RBCs releases bilirubin. 5. Frequent infections. Why? The spleen, which normally filters bacteria, becomes damaged or shrinks, autosplenectomy. 6. Delayed growth and puberty. Why? Chronic hypoxia plus poor nutrition due to increased metabolic demands. 7. Vision problems. Why? Blocked vessels damage retina, sickle cell retinopathy. Each symptom is not random, it is a puzzle piece. Put them together, and you see the full, terrifying picture of a body under siege. Diagnostic tests. To confirm sickle cell anemia, here's what the medical team relies on. 1. Newborn screening mandatory in many countries, detects disease early. 2. Hemoglobin electrophoresis gold standard. Distinguishes HbA, HbS, HbF. 3. Peripheral blood smear shows sickled cells, target cells, Howell-Jolly bodies. 4. CBC, complete blood count, reveals anemia, high respiratory count. 5. Sickle solubility test quick screening, but not diagnostic alone. 6. Organ function tests renal profile, liver function, echocardiogram, transcranial Doppler, for stroke risk in children. Remember, time is everything. Early diagnosis can mean the difference between a life cut short and a life lived with hope. Medical management. Now comes the big question: how do we fight back against sickle cell anemia? 1. Hydroxyurea. O increases fetal hemoglobin, HbF, which resists sickling. O reduces painful crises and need for transfusions. 2. Blood transfusions. O prevents stroke in children, manage severe anemia. O risk, iron overload requires chelation therapy. 3. Pain management. O opioids for crises, NSAIDs, hydration. O oxygen therapy if hypoxia present. 4. Infection prevention. O vaccines, pneumococcal, meningococcal, influenza. O prophylactic penicillin in children. 5. Folic acid supplementation. O supports rapid RBC turnover. 6. Bone marrow or stem cell transplant. O currently the only curative treatment, but limited by donor availability and risks. Surgical management. Splenectomy, for repeated splenic sequestration crises. Cholecystectomy, for gallstones caused by chronic hemolysis. Medicines and surgeries can only go so far. The real battle against sickle cell anemia is fought at the bedside, where every decision, every intervention, and every ounce of compassion can save a life. And this is where nursing becomes not just a profession, but a lifeline. Specific nursing management for sickle cell anemia. 1. Pain management. O administer prescribed analgesics on time, don't wait until pain worsens. O encourage relaxation techniques, warm compresses, and distraction methods. Why? Vaso-occlusive crises are intensely painful and worsen with stress. 2. Hydration therapy. O maintain oral fluids aggressively. Why? Hydration decreases blood viscosity and reduces sickling. 3. Oxygen therapy. O administer as ordered during crises. Why? Extra oxygen reduces sickling triggered by hypoxia. 4. Infection control. O strict hand hygiene, monitor for fever, give prophylactic antibiotics and vaccines. Why? Patients are highly prone to infections due to splenic dysfunction. 5. Preventing complications. O encourage mobility but prevent overexertion. O monitor for stroke symptoms, chest pain, acute chest syndrome, and priapism. 6. Psychosocial support. O provide counseling, support groups, and education to patients and families. Why? Chronic pain and lifelong illness often lead to depression, anxiety, and hopelessness. Nursing process assessment. History, frequency of crises, triggers, family history. Physical exam, pallor, jaundice, pain level, swelling, infections, organ enlargement. Labs, HB electrophoresis, CBC, respiratory count, LFTs, RFTs. Nursing diagnosis. Examples. Acute pain related to vaso-occlusion. Risk for infection related to impaired splenic function. Activity intolerance related to anemia and hypoxia. Impaired growth and development related to chronic illness. Ineffective coping related to chronic disease burden. Planning, goals. Patient will report pain relief within 30 minutes of analgesic administration. Patient will remain free from infection during hospitalization. Patient will demonstrate understanding of disease management before discharge. Patient will maintain adequate hydration and oxygenation. Implementation. Administer analgesics, fluids, and oxygen as prescribed. Monitor vitals, oxygen saturation, and labs regularly. Educate patient on avoiding triggers, dehydration, extreme cold, stress, infections. Encourage balanced nutrition and folic acid intake. Arrange referrals, hematology, psychology, genetic counseling. Evaluation. Pain reduced to tolerable level. No new infections during care period. Improved energy levels and oxygen saturation. Patient/family verbalizes understanding of disease, medications, and preventive strategies. Evaluation is not just about charts and numbers, it's about looking into the patient's eyes and knowing they feel safer, stronger, and more in control of their life. Sickle cell anemia is more than a disease, it is a lifelong battle written in the blood itself. But with knowledge, vigilance, and the healing power of nursing, we can turn the tide. Remember, every crisis you prevent, every infection you stop, every drop of hydration you give, could mean the difference between life and death. This was Nursing Blueprint, your guide to mastering complex conditions, one blueprint at a time. Don't forget to like, share, and subscribe, because the knowledge you gain here might just save a life tomorrow.